Hello, my name is Natavia Townsend. Today we're going to be discussing airway management, difficult airways, biads, and RSI. Oh my. So here we have listed our learning objectives for today's lesson on airway management. I'm not going to read them verbatim, but I will say that we're going to be discussing assessing a patient's airway, some criteria that you can use to determine how difficult an airway might be, especially depending on which skill you're going to be using. We're also going to discuss the pre-planning or going into performing an airway management skill. We're going to discuss the skills themselves, things to look for and troubleshoot, and then we're also going to discuss some documentation. So before we get into the actual lesson for today, I did want to hit on some important background information. So first and foremost, what exactly is airway management? Airway management can be described as the assessment, planning, and series of medical procedures required to maintain or restore an individual's ventilation or oxygenation. If you can recall back to your A&P class, ventilation is the mechanical process of moving air in and out, and oxygenation is the gas exchange that occurs on the cellular level. So if you think about airway management as a solution, the problem is that a patient has had some type of either injury or illness that has affected their body's ability to either move air in and out or to perform the gas exchange on the cellular level. I like to think of airway management as one of the most important aspects of pre-hospital care. It's critical to the patient's survival and their recovery. I think that a lot of times in EMS we can be kind of short-sighted and we have the kind of treat them and eat them mentality. However, airway management is one of those things that not only affects the here and now with the patient, but it can also affect them long-term. Your options for airway management vary wildly in levels of complexity and invasiveness. You have some procedures that are almost first aid in nature, and then you have other procedures that are incredibly complex that involve medications and surgical techniques. There are a variety of different tools that you can use when it comes to airway management, and today we're going to be discussing one of the core dilemmas in pre-hospital airway management. We're going to discuss which techniques and resources that we have available are going to best suit the needs of our patient. So when you're planning on doing any sort of airway management intervention, one thing that you really want to consider beforehand is making sure that you're doing a good assessment. Anesthesiologists, before they go in to do a surgery, they're always going to go in and look at the patient, kind of get a size up. We're always taught to do a scene size up in any EMS class. So same thing is going to go into before you're doing any airway management interventions. When you're doing this assessment, a lot of these assessments are going to be visual in nature, and so you can kind of incorporate them into your regular assessment. You don't have to do anything separate to do an actual airway assessment. And then there are some mnemonics that can kind of assist you when you're doing your airway assessments based off of the intended intervention. So the first mnemonic we're going to talk about is moans. Moans is going to be used for a patient that or used to assess whether a patient might be difficult to bag or use a BVM on. So moans, you're going to be looking at the mast seal, obesity obstructions, the patient's age, their teeth or lack thereof, and then stiff lung. So mast seal, you want to look at the patient's face. Do they have any beards, any facial hair, anything like that, any secretions that might be on their face, facial trauma, anything that's going to prevent you from getting a good seal with your BVM mask. Patient's obesity or obstructions. So larger patients are going to be a little bit more difficult to bag. You might want to have to change the patient's position. Additionally, also looking for obstruction. So are there any secretions in the patient's airway that can make bagging them more difficult? Anytime you're doing any airway management procedure, you always want to make sure that you have suction on hand so that you can take care of any blood or vomitus, anything like that. Patient's age. So as we get older, our anatomy can change a little bit. So if you think about like an older grandma or something like that, I think of them being a lot smaller, more frail, things like that. So that might alter your ability to get a good seal on the patient. That kind of goes along with the no teeth. So if a patient doesn't have any teeth, that can affect their mouth's shape, which is again going to affect your ability to get a good seal with your BVM. A lot of times if the patient is wearing dentures or something like that, it is best to leave the dentures in, then take them out so that you can kind of maintain that shape of their mouth. And then last but not least is going to be your stiff lung. Stiff lung refers to the patient having any disease or disease processes that might decrease their lung compliance. So things like COPD, asthma, or even ARDS can, like I said, decrease the compliance of the lung, making it more difficult to bag. So if you get a good medical history before you begin your intervention, that can kind of guide you, so you know what you're working with. If a patient does have some sort of disease that does lead to stiff lung, you may want to consider using PEEP. They may require more pressure, so PEEP is going to be your positive in expiratory pressure, which is just going to help keep those alveoli open when you're bagging them so they don't collapse back in on themselves, helping to facilitate that gas exchange on the cellular level. So our next mnemonic we're going to talk about is rods. Rods is going to be used to assess if it might be difficult to place a biad or a blind insertion airway device, extraglottic device, supraglottic device, whatever you want to call it. So rods is going to look at restricted mouth opening. So how wide is the patient's mouth going to be able to open? Are they going to be able to actually accommodate whatever device you plan on inserting? Again, we're going to look at obstructions or obesity. Is there any, contaminants or secretions in the airway? I know for eye gel specifically, secretions can prevent you from creating a good seal, or prevent the device from being seated properly. So again, you want to keep your suction on hand. Also want to look at any disruptions or distortions in the patient's airway. So things like trauma, tumors, just any anatomical changes that alter the normal shape of the patient's airway. These can again make it more difficult to obtain a proper seal with the device, as well as the function of the device. So it can prevent the air from actually entering into the patient's airway that the device is kind of facilitating. So last but not least, stiff lung again, COPD, asthma, ARDS, all these things can make lung compliance more difficult. Again, you might want to consider using PEEP on these patients. So our next two mnemonics that we're going to use are going to be lemon and heaven. These two are going to be used for intubation. Lemon, I feel like, is better for a more controlled in-hospital setting. It's also a little bit better when using direct laryngoscopy, whereas heaven, I feel like, is better for an out-of-hospital setting and when using video laryngoscopy. So lemon, the first thing that you're going to do with lemon is going to advise you to look. You want to perform your, kind of external observation of the patient, looking for any external conditions that might make intubation more difficult. So these are things like facial trauma. Does the patient have a short neck, a small mouth? Do they have prominent teeth or no teeth? Do they have a large tongue? All these things that might make the intubation more difficult. Next, you're going to go to evaluate. So when you evaluate, you're going to use the 3-3-2 rule. So the 3-3-2 rule is going to ask three different questions. The first question is the person able to fit 3 fingers between their teeth? You want to use the patient's fingers, but 3 fingers between their teeth. This is going to assess their ability to open their mouth. Again, kind of like when you're at the rods method, looking at restricted mouth opening. It's also going to look at the length. Is the length from the bottom of the chin to the hyoid bone at least 3 fingers? This is going to evaluate if there's enough space for intubation within the pharynx. Last is going to ask, is the distance between the hyoid bone and the thyroid cartilage or the Adam's apple at least 2 fingers? This is going to assess the position of the pharynx relative to the larynx. If the distance is less than 2 fingers, this suggests that the larynx may be positioned higher in the neck, making it more difficult to see the vocal cords. Then you're going to look at the Mallampati score. Mallampati score is going to look at the kind of internal airway of the patient, kind of the back of the mouth. So looking at, can you see the uvula? How much of the tongue can you see? Can you see the tonsils on the side? Based off of what you can see when you look inside the patient's mouth, the patient is going to be given a grade from a class 1 to a class 4. The higher the class, the more difficult the intubation is going to be perceived to be. Again, we're going to look at obstructions or obesity. Is there any secretions? Again, having your suction on hand. Suction is going to be super important. And last but not least, you're going to look at neck mobility. So is there some reason why the patient is not able to move the neck? Positioning your patient is going to be super beneficial when it comes to performing any airway management technique. So can you kind of extend the patient's neck at all? You want to try to create a straight line from the ear to the sternal notch, kind of opening that airway up. And does the patient have any type of mobility issues that may prevent their neck from doing that? So think of grandma with kyphosis, or if you have a trauma patient and you have a C-collar applied, these are things to consider. Last but not least, we have our Heaven mnemonic. So again, Heaven is better for VL, and I think the out of hospital intubations. Heaven differs from some of the other mnemonics and assessment techniques because not only does it take into account anatomical considerations, but it also takes into account physiological factors, especially when you're considering things like RSI. So things like post-intubation, or peri-intubation, like hypotension or hypoxemia. These can be correlated with peri-intubation cardiorespiratory arrest. So evaluating these things beforehand can kind of give you a good idea as to whether or not this is going to be a difficult intubation. So first thing with Heaven, you're going to look at hypoxemia. So does the patient have a low oxygen saturation going into the intubation attempt? If so, that suggests that it may be more likely that they are going to be a difficult intubation. If you think about the causes for why their oxygen saturation is low, that can kind of give you a good gauge as to why they might be a difficult intubation. Next, you want to look at the extremes of size. So again, we've talked about with all airway techniques, obesity being a factor, but in the alternate, we haven't really talked about peds, but peds is a consideration if you have a really small patient as well as really large patients. These can make it more difficult to intubate your patient. Also want to consider any anatomic disruptions. So is there any sort of physical condition that might make intubation more difficult? So these are things going to be like trauma, swelling, foreign objects in the patient's airway that are going to make it difficult for you to visualize once you get in with the laryngoscope. Vomit, blood, fluid, again, secretions, again, these go along with the obstructions that we talked about in the other assessment techniques. Again, you want to make sure that you have your suction on hand. Next, we have exsanguination or anemia. If the patient is suffering from significant blood loss or anemia, this can lead to faster desaturation during the intubation process. So kind of having an idea of that going into your intubation attempt can kind of set the stage and know what you're working with, and allow you to plan for it going forward. And again, neck mobility, things like trauma, are these going to prevent you from being able to place the patient in a position that's going to facilitate your best attempt at obtaining that airway access? So after you've done all your assessments, they can kind of guide you into what you might be walking into. This can then transition into our next step, which is going to be planning. So the next thing we want to talk about when working with airway management or considering airway management is your plan, or creating your plan. I think that a lot of times in EMS, we like to think that, oh, we can just kind of fly by the seat of our pants. We don't really plan. We just kind of wing it. But I think it's really important to have a plan, especially in those situations. But the kind of winging it nature comes in the ability to adapt your plan when necessary, kind of on the fly. And so part of helping you go into your plan is that once you've completed your assessment, and so you kind of have an idea of what you're working with your patient, that can kind of guide you on where you need to go. Do you need to start off more invasive or less invasive? Is it a matter of starting off with, maybe your patient, you can start off with just bagging your patient, right? Then considering, okay, maybe I need to bag my patient, then I need to add some type of airway adjunct. After I add my airway adjunct, is that working? If not, then maybe I need to consider inserting a biad. Is that allowing me to be successful? No. Okay, maybe I need to move on to something even more invasive, like intubating the patient or performing an RSI. Is that going to be useful? If not, maybe then I need to consider a surgical crike or some sort of surgical airway a quick trach if that's what your service has. So all these things are having an idea of what you might need to do before you need to do it is going to definitely help you set yourself up for success. In addition to considering what interventions you need to be doing and have like a set plan for how you're going to do it, you also want to make sure that you're communicating really well with the other members of your crew or your team, making sure that you're assigning roles and who knows what they're doing when it comes time to actually perform the actual interventions. Make sure there's no misunderstanding. Everybody understands what exactly is that they're supposed to be doing. Again, this is going to set yourself up for success, also making it so that you can have the best possible outcome for your patient. And you also want to, all these things are going to help you set yourself up for a first pass success strategy, right? So having the good plan, knowing what you're doing, who's doing what, are going to make it so that if you are intubating the patient, right, the first time that you attempt to intubate the patient, or the first time that you're trying to do any intervention really, making sure that you're as successful as you can possibly be. So some other things that you can kind of consider when it comes to planning is, your need to pre-oxygenate the patient, especially if you're planning on, intubating the patient or something like that. Using a nasal cannula to pre-oxygenate the patient can go a long way. Moving your patient to a place that you have to work. You don't want to be, in a cramped bathroom. So if it's something as simply moving your patient to the living room, not necessarily moving your patient all the way out to your patient, but moving yourself to an area where you have more room to work, again, where you can set yourself up for success to be more successful. Again, this is also if the situation allows, but planning going into this so that you know what you're working with. I know a lot of providers like to get your patient into your office or the ambulance as soon as possible. Sometimes that is going to be more beneficial. Other times it's not. Sometimes it is safer for yourself and the patient to kind of work where you are. Again, planning on how you're going to position the patient, a matter of elevating the patient's head or torso, creating that airway alignment to, again, open up that airway. And again, if you're trying to intubate somebody, while is it possible and it's sometimes the only way that you can do it, but laying on the floor is not the ideal way that you would like to intubate a patient. So planning on what you might need in order to position your patient properly. So a matter of grabbing towels, sheets, blankets, pillows, whatever you have available to you. And although, we like to train in really bright rooms and classrooms and things like that, that's not always the case in the real world. So planning on, are you going to have enough lighting? Can you have somebody run somewhere else and get a flashlight or something like that? So again, setting yourself up for success is what planning is going to be all about. And this kind of goes to the first pass success strategy, but I think one of the most important parts of planning is making sure that you have your proper equipment. Again, making sure that you checked off the truck that day, making sure you have your oxygen, making sure you have your properly sized equipment for your patient, making sure that you know how to properly size your patient, the equipment for your patient. Suction, making sure you have your suction available and ready and it's working. If you're a portable suction, making sure that it was charged. So all these things, when it comes to planning, are going to, again, help you be more successful and provide the best possible outcome for your patient. So now that we've kind of discussed the airway assessment and the planning of your airway procedures, now we can kind of look at the actual techniques themselves. So talking about airway management, oxygenation is always going to be a big one. So first thing when it comes to, oxygenating your patient or, good BVM technique, it's going to be positioning your patient. Positioning is going to set yourself up for success. So sniffing position is definitely something to consider. It is recommended for peds, but I like to place all my patients in sniffing position. It's not going to hurt. Again, it's opening up that airway. Again, you want to create that ear to sternal notch, that straight line. And again, sniffing position can kind of help you do that sometimes. Ramping the patient can also be successful. So it's a matter of, lifting the head of the patient up if they are in a supine position. Again, that's going to help open up the airway. It's particularly useful for your more obese patients. So In addition to positioning your patient, pre-oxygenating your patient is going to be super important when doing any airway management technique. So sometimes it's as simple as, placing a non-rebreather on a patient while you're, preparing supplies or something like that. BVMing the patient is another pre-oxygenation technique. You may have had the patient on CPAP before you decide that, hey, this is not working for the patient, or the patient's mental status is, decreasing, and CPAP is you're not gonna be able to sustain the CPAP. So all these things are kind of important ways to get oxygen inside your patient before beginning your more advanced airway management techniques. Apneic oxygenation is another thing that's kind of on the rise, especially when you're considering RSI procedures. So placing the patient on a nasal cannula after you've administered your paralytic and your sedative. Nasal cannula at 15 liters, kind of passively getting the patient some oxygen has been shown to be very beneficial to patient outcomes. However, you want to make sure while you're doing any of this that you are following your protocol. And last but not least is the BVM. So the BVM is going to be your most basic of your more advanced airway management techniques. I know that sounds kind of complicated, but contradicting yourself. But BVM is a BLS skill, but we like to remember BLS before ALS. But if you are at the point where your patient needs to be BVM'd, that is a more serious situation than them just needing like a non-rebreather or CPAP, something like that. So when it comes to BVM, you want to make sure that you're practicing good BVM technique. Ideally, a patient should be bagged with 2 people. However, I understand that, research may not always allow that, but when you can, you want to make sure that you're trying to use as many people as possible, preferably 2 people. So you want to make sure that you're practicing your good techniques when holding your mask seal. So one technique that you can use is the 2 thumbs up. So actually have 2 thumbs on the side of the BVM mask. You can kind of rest your fingers along the patient's jawline. That can allow you to do like a modified jaw thrust or something like that while also maintaining a good seal. If you can't do the 2 thumbs up method, the double EC method is another thing that you can use, where you're using your thumb and your index fingers to hold the mask seal, and again your other 3 fingers are going to go along the patient's jawline, and again that allows you to do a modified jaw thrust if necessary. When you're bagging your patient, you want to make sure that you're paying attention to your rate and your volume. You don't want to bag too fast. You also don't want to bag too slow. You don't want to bag too much. So when you're bagging your patient, you want to bag just enough to get some chest rise and fall. And then in terms of your rate, for a cardiac arrest setting, bagging your patients probably every 5 to 6 seconds. And then if your patient does have a pulse, you want to make sure that you're trying to maintain as close to a possible normal end-tidal range, so 35 to 45 millimeters. Again, all these things are going to try to help you avoid any hyperventilation. So we've talked about your airway assessment, we've talked about your plan, we've kind of gotten into the plan some with like your BVM technique, you're oxygenating your patient. Now it's time to move on to BIADs. So BIADs, or blind insertion airway devices, sometimes they're also called supraglottic airway devices, extraglottic airway devices. These are going to be more invasive than your standard BVM technique, but not quite as invasive as like an intubation. You're simply going to put in the patient's mouth. You don't have to, look in, or you're not looking at any anatomy or anything like that, so to speak. You're just kind of inserting the device, and then that allows you to have an airway. A lot of different types. You have your LMAs, your king tubes. Pictured above, we have iGels. It just kind of depends on what your service has. You want to make sure that you're familiar with whatever BIAD that your service uses, so that you know how to use it properly. Also, it's important to know, depending on the type of BIAD that you have, how they are sized, so that you're placing the appropriate sized BIAD in your patient. So indications, you want to talk about, think about what might lead you to think that you might need to use a BIAD. We talked about it in our plan before. It might be a matter of, based off your plan, you felt that your patient needed intubation initially, and you attempted intubation but were unsuccessful, a biad is a great option when you've had a failed intubation attempt. It's a lot quicker than attempting an intubation again, while still allowing you to establish an airway for your patient. Also, depending on your service, some services may prefer that you place a biad in a cardiac arrest setting. So just kind of make sure that you're following your protocols. Also, resources. If you have limited resources, a biad may be a better option for you. If your service doesn't allow for intubation or you don't have the intubation tools, a biad is a quick, easy, often easy insertion process that you can use to make sure that you're establishing an airway for your patient. Selection, we talked about it briefly before. In terms of sizing, making sure that you're selecting the appropriate size for your patient. Eye gels, I know for instance, are based off of patient weight. So kind of estimating your patient weight and then selecting the appropriate size for your patient. And then after you've selected a size, you also want to make sure that you're confirming that, it's fitting properly with, like your depth markers on the device. We will go over the insertion steps later on when we do our skills drill, but essentially with a biad, you're just kind of sticking it in the patient's mouth. You want to make sure that the airway opening hole is down. With the eye gel particularly, you just kind of follow the patient's anatomy. Again, we'll discuss it later on in skills. Then when it comes to confirming the proper placement of the eye gel, the gold standard to any airway management technique is going to be end-tidal CO2. So making sure that you're trying to maintain that 35-45 on a patient with a pulse. If the patient is pulseless, again, getting your end-tidal as high as possible. Again, you also want to look for any sudden increases and might suggest ROSC. Just considerations to make with your end-tidal. But also you want to make sure that you're having chest rise and fall. You want to listen to breath sounds, and then also watching your SpO2 trends as well. Is the patient desaturating for any reason? And then troubleshooting, when it comes to a biad, they are typically quick and easier, but that doesn't mean that things can't go wrong. So also being aware of what devices that your service uses so that you can be prepared to troubleshoot any issues that might arise with it. So with the eye gel, sometimes they can become unseated if the patient has a lot of secretions or anything like that, and you don't necessarily have the proper seal. That might be something where suction is needed. Before you insert the device, you want to make sure that you're inspecting it, make sure that it's not faulty in any way. If it is faulty, again, that can cause any problems. Again, like I said, secretions, if the patient starts vomiting, that can cause issues. A lot of the larger sizes of eye gels have a channel in it that you can actually insert an OG tube that can kind of help prevent some regurgitation, not always, but if it does happen, it still allows you an option for suctioning as well. Again, talk about the losing the seal. They can come unseated, reseat the device if necessary. Size, you might have gone initially off the size, but for whatever reason, the patient's internal anatomy might be a little bit different and they might require a different size than what's necessarily recommended. So that might be a consideration, so you might have to switch out the size. And also PEEP. Again, we talked earlier about, the stiff lung diseases and things like that. So the patient might have some sort of disease process that is going to require them to need more pressure. So adding a PEEP valve to your BVM attached to your biad might be necessary as well. So now we've discussed BVMs, biads. The most invasive airway management technique that we're going to discuss in this particular class is going to be intubation. You can go a step further and go to like a cracking procedure. But we're just going to talk about intubation for today. Intubation and RSI. So RSI is a type of intubation essentially. You're still going to use that same intubation skill, but when you're discussing an RSI, that's going to involve medication administration in addition to the actual intubation process. The medication is going to be used to facilitate the intubation essentially. So what are going to be some indications for you to intubate your patient or to use the RSI technique? So a big one is going to be failure of your patient to oxygenate or ventilate. We kind of talked about that earlier. That's with your airway management in general. You want to make sure that your patient has that ability to oxygenate and ventilate. But if your patient is unable to do that, intubation may be a good option for you. Also, particularly with RSI, the patient's ability to protect their own airway. So if the patient is unresponsive, and you have concerns that they might vomit or something like that, they might have a head injury or something like that. All these are considerations that you would take into account that might make RSIing the patient or intubating the patient your best option. And also another thing is, your anticipated clinical course. So what is the projected outcome of this patient? So some of your contraindications, so why you wouldn't want to intubate your patient or RSI your patient. Obviously, if you don't know how, don't do it. So skill level of the provider, resources available, RSIing especially, you're going to require paralytics and a sedative. Does your service carry those things? If not, obviously you're not going to be able to do it. So don't. But again, like resource limitations, skill limitations are big ones. Also, your ability to ventilate the patient after you've pushed the paralytic. So if you think about, especially with RSI, you're taking away this patient's ability to breathe at all. So if you take that ability to breathe away and then you don't have anything to help them afterwards, right, that's going to cause some problems. So definitely wouldn't recommend it if you don't have an ability to, ventilate the patient once the paralytic has been administered. So with RSI, a lot of places recommend that you use a checklist. A service I worked at Press, we had an entire RSI timeout. So before we actually initiated the RSI procedure, we took time, we stopped, we went through our checklist and went over making sure that, we had all our proper equipment available. We had all our personnel. Everyone knew their roles, knew what they were doing in the process. We made sure that we had all your backup plans available. So intubation obviously is going to be your go-to when you're RSIing the patient, but making sure that you have your BIAD still available, making sure that you have a surgical crack available if necessary, making sure that your BVM is available, any airway adjuncts to go along with the BVM are in close proximity. All these things you want to make sure that you're going through in your pre-brief or your checklist or your timeout, whatever you want to call it. Also, you want to make sure that you have suction available. Again, suction should always be on hand when you're doing kind of any more invasive airway procedure. If you are RSIing your patient, you want to make sure that you have your proper medications drawn up at the proper dosages. Your sedative is always going to be administered first, and then your paralytic, again, following your local protocols and procedures. If you need making sure that you have a bougie on hand, that's another thing that you want to make sure that you're going through and checking off before you actually initiate the procedure. And then once the procedure has been completed, so you have successfully intubated the patient, your ability to confirm the intubation. So again, end-tidal is going to be your gold standard. Chest rise and fall, listening to lung sounds, the lack of epigastric sounds, making sure that you secure the tube, noting where the tube was secured. All these things are going to be things that you're going to want to make sure that you're looking at when doing these procedures. If for whatever reason your intubation is unsuccessful, so making sure, like we said when we talked about our planning procedure, making sure that you have your plan and you know what your next steps are in your plan. And then something that I think can oftentimes be overlooked, but making sure that you're also pre-preparing for your post-intubation care. So is your patient going to require more sedatives? What exactly is your patient going to require from you once the tube has been secured? So having an idea of what you're going to need for that, either medications, having those medications on hand, making sure the medications have been drawn up at the proper dosages per your protocol. All these things are going to be incredibly important. And when considering RSI or intubation, making sure that you're aware of any complications that you might face and your ability to manage those complications. Some big ones when it comes to intubation is going to be desaturation. So is the patient's SpO2 dropping while you're bagging them? If so, sometimes it does require you to abort the patient. Not abort the patient, but abort the procedure. and go to something else, switching to your plan. Again, adapting to your changes in your plan quickly, so that you can effectively manage the patient's airway. Again, something you can kind of do to prevent that is apneic oxygenation. So applying that 15 liters via nasolacanal to the patient while you're actually performing the intubation, that can kind of help decrease the risk of desaturation, but it's not always a guarantee. So still being prepared if that should happen. When you're discussing your roles, you want to make sure that you have somebody watching the monitor for any desaturations, so that you can be prepared if and when it does happen, and act accordingly. Hypotension is another thing to consider that can be a contraindication, especially if you're doing an RSI. Medications can occasionally cause the patient's blood pressure to drop, or the patient's blood pressure could have been low to begin with, and then during the procedure it just continues to drop. So pressors, push-dose pressors especially, are beneficial, but again, you're going to want to make sure that you're going off of whatever your services protocols are. Aspiration, so is there any secretions in the patient's airway? Are they getting into the lungs? Being prepared and acting accordingly with that. And again, when it comes to RSI or intubation or any airway management procedure in general, it's not to say that there won't be complications or things won't necessarily go wrong, but your ability to handle them or manage them and adapt to them is going to be the big difference when it comes to taking care of your patient and making sure that your patient has the best outcome possible. So now that we've kind of discussed all the different airway management techniques, I do want to kind of go over difficult airways before we start getting into skills. So difficult airways or failed airways, you've done your assessments. All your assessments can kind of allow you to gauge if your patient might be a difficult airway. If you think that your patient might be a difficult airway, you want to make sure that you're planning accordingly. So if you're going to be intubating, video laryngoscopy is going to be your best bet over direct. So starting off with that, positioning your patient, attempting the ramp position, making sure your patient's in the sniffing position, considering having a bougie available or using a bougie initially for that difficult intubation. And also making sure that you have a biad close by on hand should that you get in there and you have a failed airway attempt. Another intubation attempt is going to take more time than insertion of a biad, so having it on hand is another consideration for difficult or failed airways. A failed airway is going to be considered 2 or more failed intubation attempts or an SpO2 less than 90%, despite optimization. So you've done everything you can, but you can't get it over 90%. If that should be the case, especially when you're intubating a patient, move on. Obviously what you're doing is not working, so again, making sure that you're adapting your plan to what you are presented with quickly, so that your patient can have the best possible outcome. If a biad is not an option, you may have to consider going the opposite direction into a surgical airway, so a crike of some type, but again, knowing when to move on, so that you can be the most successful or provide the patient with the best option for survival. The kind of big emphasis I want to make when it comes to difficult airways or airway management in general is oxygenation wins over intubation anytime. I am a provider who loves to intubate, but I understand that sometimes this is a fight that I'm not going to win, and I have to put pride aside, and this intubation might be a failed intubation attempt, but I need to make sure that I am oxygenating my patient properly over anything else. Making sure that gas exchange is occurring so that the patient has the best chance of survival. I'm not creating any anoxic brain injuries. I'm not causing any death to any organs, anything like that. Everything is staying perfusing properly. So we have discussed our airway assessments. We've discussed our creating of our airway plans. We've discussed some different airway management techniques, the BVM, biad, insertion, and intubation/RSI. So now let's practice some skills. We're going to be discussing some airway management skills. First skill we're going to be discussing is utilizing a BVM or bagging the patient. Just like with any other skill in EMS, you want to make sure before you begin the skill you have your proper PPE on. Anytime you're doing anything with airway management, gloves are the bare minimum. Airway management, I also like to utilize eye protection. One of the most common exposures that providers can get is through getting secretion in their eye. So eye protection is super important. Also, because we are dealing with the airway in the era of COVID and other respiratory diseases, a mask is something that you may want to consider as well. So once you have your proper PPE on and you're going to be BVMing your patient, you also want to make sure that you get all your proper supplies together. You want to make sure that they are the appropriate size for your patient. Once you have your appropriate supplies, your proper PPE on, then you want to focus on making sure that you are assessing your patient. As we discussed earlier, you can use your MOANS acronym to determine if your patient might be more difficult to bag. Once you've assessed your patient, you have your supplies, you have your PPE on. You want to make sure that you're positioning your patient in the proper position. You want your patient's airways to be as straight as possible. So you want your ears to be in line with their sternal notch. Ideally, you might have to extend the patient's neck some. Your patient will most likely be in the supine position. If your patient has mobility issues or they have, a short neck, something like that, it may be beneficial to use towels or a blanket or something, some sort of padding to get the patient in the sniffing position. Sniffing position is most often associated with pediatric patients, but I like to use it for any patient because it's not going to hurt. So once you have the patient in the proper position, you have all your supplies. Again, like we said with MOANS, you want to make sure there's no obstruction, so no secretions, anything like that. If you do, you want to make sure that you have your suction on hand. You can suction anything out. Then when you go to use your BVM, you want to make sure that you have a good mask seal. BVMing ideally should be a 2-person job. However, I understand that with EMS, that's not always possible. It may just be you. If you do have 2 providers, one provider's job is going to be purely to maintain the proper seal. When they're maintaining the seal, you want to make sure that your mask goes over the patient's nose. It's going to cover their entire mouth. You don't want any air leakage around. You can use a couple of different ways to actually hold the seal. One is the EC hold. So you're going to take your thumb and your index finger of both hands, and those are going to go on your actual mask. You're going to press down, and then you're going to take your other 3 fingers and you're going to hold along the patient's jawline. You can use this to kind of do a modified jaw thrust as necessary, but making sure that you're getting a good seal. Another way that you can hold the seal is the 2 thumbs up method. So you're going to hold on the side with your thumbs up. And again, this allows you to get all 4 fingers kind of in the patient's jaw. And you can also do a jaw thrust in this position as well. So once you have a good seal, you also want to make sure that you have your end tidal attached as well. You want to make sure that you're monitoring your patient's end tidal. That's going to be your gold standard when it comes to monitoring patients during airway management. Have your end tidal monitor, you have your BVM attached, you have your good seal. If it is just one provider, you can still use the EC clamp. So you're gonna have your thumb and your index finger on the mask, you're gonna press down. Again, your other 3 fingers are gonna go along the patient's jawline, and you're gonna bag. You wanna make sure you're watching out for your rate and your volume. You don't wanna bag too fast and you don't wanna bag too much. A blind insertion airway device or a biad. Specifically, we're going to be using the iGel today. So for whatever reason you've been bagging your patients, that is not adequate. You need to move further down in your airway algorithm, or as we talked about earlier, you need to change your plan. You decide that you're going to insert the iGel. First and foremost, like with any other skill, you're going to make sure that you have your proper PPE on. Again, we're going to go gloves, eye protection, and if you should choose a mask, it's optional as well. Again, you're going to make sure that your patient is in proper position. Same with bagging your patient. Sniffing position, make sure there's a straight line in the airway from the ear to the sternal notch. Make sure that you have all your equipment is appropriately sized. You can also be assessing your patient while you're getting everything ready. For our blind airway devices, we're going to use our RODS acronym that we discussed earlier. Making sure that we're making note of anything that might make the insertion of the iGel more difficult, and if so, we are prepared. So first and foremost, we're going to be bagging our patient.
like I said, for whatever reason, it's not adequate, make sure that you are communicating with your partner. This is going to be a multi-person skill, as most airway management skills should be. However, that may not always be the case, but is preferred to have multiple people to assist. So again, you're gonna be monitoring your patient, communicating with your partner, making sure you have your end tidal, your SpO2 readings going. Once you've communicated with your partner that you're going to be placing your i-gel, I like to first and foremost go ahead and get my securing device prepared. I'm gonna place it up under the patient's neck, have that ready for me. My partner is still gonna be bagging my patient. I'm gonna take my i-gel, make sure it's the appropriate size. You're also gonna need lube. The i-gel is gonna come in this container, so to speak. Remove it from the container, and what I like to do with my lube is I like to empty the lube out on the i-gel container and then apply it to my actual i-gel device from the container, making sure that it's nice and lubed up. Once I have my device ready for insertion and I've communicated with my partner that I'm ready to insert my i-gel, my partner, who is going to be bagging the patient, is going to remove the bag valve mask, put the BVM with the end tidal still attached to it to the side. I always like to take the mask and place it on the patient's chest so that I know where it is in case I should need it for whatever reason. Once I'm ready to insert the i-gel, I like to use the scissor technique to open the patient's mouth. I'm gonna push down on their lower jaw and kind of pull up on their upper jaw. If there is any secretions or anything that I notice, any obstructions, I also want to make sure that I have my suction ready, that I can use that to clear out anything in the patient's airway. Again, using the scissor technique to get the patient's airway open. I'm going to insert the i-gel. You want the opening side down. You want to follow the patient's anatomy, and you just kind of slide it in. You want to slide it in until you meet resistance. That's how you know it's properly seated. Once it is properly seated, you can go ahead and secure the device. You want to keep a hand on it, and you're just gonna attach the holes on the strap to the side of the device. They have little notches there for you. Make sure you pull it taut so your device doesn't move at all. Once your device has been inserted, you can take your BVM with your end tidal, attach it, and you can bag your patient. You want to bag just enough to get some chest rise and fall. Want to make sure that you're monitoring the patient's end tidal again, their SpO2. You can also have somebody confirm the placement in addition to the end tidal, which is the gold standard as we mentioned before, by also listening to lung sounds. So I have made the decision that the next step in my airway management is that I'm going to intubate my patient. I've prepared all my supplies. I have everything readily accessible to me. I have everything that is the appropriate size for my patient. Make sure that everything's in working order. While I'm doing this, I've assessed my patient using my LEMON and my HEAVEN acronym. I'm prepared for a difficult intubation if I suspect that there is one. Additionally, intubation is going to be a multi-person procedure. You're going to need extra set of hands when performing an intubation. So while I would be getting everything ready, I would have my partner or someone else on the truck or wherever I am bagging my patient, ideally. But you do want to make sure that you're pre-oxygenating your patient somehow, whether it is bagging or providing apneic oxygenation with a nasal cannula, a non-rebreather, you have the patient on CPAP, or you have a biad placed. Any of those things, you want to make sure that you're pre-oxygenating your patient. You're going to make sure that you have a good view on the monitor so that you can monitor the patient's SpO2. Prior to starting the actual intubation, you want to make sure that the patient's SpO2 is as high as it can possibly be. You also want to make sure that you're keeping an eye on the patient's end tidal. So I've decided that I'm going to intubate my patient. I have my partner bagging, make sure I'm communicating with them when I'm ready, have all my supplies ready. While they are bagging my patient, I am going to go ahead and get my securing device for my ET tube and place it up under my patient. So I have my securing device placed, patient's in the proper position. Again, communicating with my partner, okay, I'm ready to intubate. They're going to remove the mask. Again, we're going to place it on the patient's chest so we have easy access to it. We're gonna make sure that we keep the end tidal monitoring device and the BVM together, place those to the side. When I go to intubate, I'm gonna have my laryngoscope blade in my left hand, and I'm going to have my suction in my right hand. Your blade is always gonna go in your left. Doesn't matter you're left or right-handed, it's always gonna go in your left. And I like to have my suction in my right hand, especially when I do my initial pass through the teeth. So I'm gonna go in with my suction, get any secretions that might be in there out of the way. I'm gonna take my blade. I like to start on the right side of the patient's tongue and kind of sweep to the left. Helps me move their tongue out of the way. So I insert my blade sweeping to the left. And then as I insert, I'm going to pull up on the patient's lower jaw. You always wanna make sure that you pull up, not back. I always remember cheers, not chug. So I'm gonna go in and I'm pulling up on the patient's lower jaw until I can get the view. I want to be able to see a view of the patient's vocal cords. Once I have a view of the patient's vocal cords, I'm going to take my ET tube with my stylet and my syringe preloaded on it. You may need to use lube. I'm going to insert it into the patient's airway, going between the vocal cords. When I insert my tube, I want to pay attention to the depth of my tube. I want to mark it. Right now I'm at 23 centimeters to the teeth. I'm gonna remove my blade, lay it to the side. I always wanna make sure that you keep a hand on your tube. I'm going to insert my bulb on my ET tube, remove my syringe so I don't lose any air. I'm also going to pull my stylet at this time. I'm gonna again communicate with my partner so they can get my BVM ready, attach the BVM to the ET tube. Again, make sure that you're keeping a hand on your ET tube at all times. Again, you're marking it. I'm at 23 to teeth. Want to make sure anytime you move the tube, you're not dislodging the tube or any way, shape, or form, or you're not going too deep. So once I've connected my BVM with my end tidal, I'm going to bag my patient, make sure I get equal chest rise and fall. Right now, I can see that I have that. You're going to have somebody confirm your tube placement by auscultating for lung sounds. You're also going to listen for epigastric sounds. When intubating, you do not want to have any epigastric sounds. You only want to have lung sounds. So I'll make sure I have my lung sounds, no epigastric sounds. I'm also going to be looking at my monitor, making sure that I'm getting end tidal capnography. Make sure that my patient's O2 saturation is maintaining as well. If all that is confirmed, my tube is good. Ideally, I would keep this attached, but for demonstration purposes, you're going to then secure your tube. Again, making sure you're marking where your tube is. I'm still at 23 to the teeth. I'm going to insert my device. All right, I have my device. I'm 23 to the teeth. Secure my tube. Make sure I'm holding it still. Connect the strap on the other side. Again, making sure I'm still, haven't dislodged it, haven't gone too deep, haven't pulled it out any, haven't gone in any further. And my tube is still good, and I have successfully intubated my patient.